23.7 months with Dato-DXd, which when you think about that, that's 2 years compared to the historical 1-year median OS with chemotherapy that we saw a decade ago.
And then what about the time to event analysis for the two trials? Can you talk about PFS in both studies?
Yeah, so both studies...
I know that was the primary endpoint for, at least in one of the,
yes,
both trials,
both
it was
trials,
one of the
yes,
primary
yes,
endpoints.
yes.
In TB02, it was combined PFS and OS. Yeah. Dual
So,
primary endpoints.
exactly.
Yeah.
So both studies met the PFS endpoint. So both studies met their primary endpoints.
Yeah.
And the improvement, the hazard ratio in ASCENT-03 was 0.62. The hazard ratio in TB02 was 0.57.
Mm-hmm.
The absolute delta in median PFS was larger in TB02. So it was 5.3 months. 10.8 versus 5.6, but with the rounding, I think it's 5.3 months of a difference compared to 2.8 in ASCENT-03. And here, I think there's been there are a lot of considerations in terms of how the control arm performed in each study.
Mm-hmm.
The control arm in TB02 had a slightly shorter median PFS than that in ASCENT-03, and one might hypothesize that perhaps that's due to the differences in the patient population, right? But I think one important note is actually if you go to historical control and you think of the median PFS of standard chemotherapy for first-line PD-L1 negative metastatic TNBC, in KEYNOTE-355, the median PFS was 5.7 months, so not far from how the control arm performed in TB02. And so certainly what I do think was important to also note was that the 6-month PFS rates for both of the trials were relatively similar. But I think robust PFS benefit with the Trop-2 ADC in first-line setting.
I mean, I think the take-home message for our listeners is listen to your biostatistics professors. When you have different patient populations, don't just compare the Kaplan-Meiers side by side. Cross-trial comparisons are hazardous at best and probably shouldn't be done at all in this case. I assume there aren't enough events yet in ASCENT to talk about OS, whereas we do have OS data in TB02.
Yes, so ASCENT-03, this primary analysis was PFS analysis, and the OS analysis was intended to be descriptive. So the formal OS readout is not, we await the data. There were 37% of events, of OS events in ASCENT-03, and at this early time point, there appears to be no numerical difference between the treatment arms. Yeah. The authors did present an exploratory PFS2 analysis that did show that PFS2 was prolonged in SG versus chemotherapy, but whether that will be a surrogate endpoint of OS remains to be seen. Sure. In TB02, with about 54% of maturity of OS events, the study met its OS endpoint with a hazard ratio of 0.79 and a approximately 5-month delta in median overall survival. And it reached 23.7 months with Dato-DXd, which when you think about that, that's 2 years compared to the historical 1-year median OS with chemotherapy that we saw a decade ago. So still much more work to be done, but significant progress for patients with metastatic TNBC.
And that was statistically significant.
And that was statistically significant, yes.
Both co-primary endpoints,
yes.
including OS. That's impressive.